Welcome back to Neurology 101, where we break down the brain one cranial nerve at a time. I'm Dr. G, and today we're continuing our sub-series on the cranial nerve syndromes. Up next is a cranial nerve VII palsy, and we're doing a head-to-head comparison between Bell's palsy and central facial palsy. These are two classic presentations that test your knowledge of upper versus lower motor neuron lesions, so let's dissect them. Did you know that the facial nerve, or cranial nerve 7, controls not just facial expression, it also carries taste from the anterior two-thirds of the tongue, supplies lacrimal and salivary glands, and even helps dampen out loud noises via the stapedius muscle. Let's take a little deeper look into the kinder patho. What is a cranial nerve 7 palsy? A facial nerve palsy is weakness or paralysis of the muscles of facial expression on one side of the face. The location of the lesion, central or upper motor neuron, or peripheral, lower motor neuron, determines the distribution of the weakness. In upper motor neuron lesions, example, a stroke, the upper face is spared due to bilateral innervation. In lower motor neuron lesions like Bell's palsy, both upper and lower face are affected on the same side. So, what's our typical clinical presentation? A peripheral or Bell's palsy has a sudden onset of unilateral facial weakness, and it involves both the upper and the lower face on the affected side. They can't close their eye or raise their eyebrow. They may have associated symptoms like ear pain, hyperacusis, altered taste because of effectiveness of the anterior two-thirds of the tongue, or dry eye. What about central facial palsy, affecting the upper motor neuron? Well, we're going to see a lower facial weakness only. It's going to spare the forehead. So patients can still raise both eyebrows due to bilateral cortical innervation of the upper face. It's often associated with stroke or other CNS lesions like hemiparesis and speech disturbance. How do we make the diagnosis? Well, clinical evaluation is key. If we have forehead involvement, we're going to think more peripheral or Bell's palsy. If we have forehead sparing, we might think of central or upper motor neuron lesions. If a central cause is suspected, like a stroke, we need to perform urgent neuroimaging, like CT or MRI. For Bell's palsy, the diagnosis is clinical. Further workup, like Lyme titers or MRIs, if it's bilateral, recurrent, or atypical in their symptom presentation. How do we treat it? Well, Bell's palsy, we're going to treat with oral prednisone. We usually try to give it within 72 hours of the initiation of symptoms, and this improves recovery. We also want to consider adding acyclovir or valacyclovir if severe or suspected viral etiology, like HSV or VZV. We also need to give eye protection via artificial tears or an eye patch to prevent corneal damage. Most patients recover fully within weeks to months. Central facial palsies, we need to identify and treat the underlying cause, stroke protocol, tumor, or MS, and refer to neurology as indicated. Appropriate tip here is the forehead holds the key. If a patient can wrinkle their brow, think central. All right, now let's look at the book med versus the street med. So, book med, Bell's palsy is a sudden onset peripheral facial paralysis. You memorize prednisone dosing and learn how to distinguish it from a stroke by examining the forehead movement. Street med, your patient says, "My face just stopped working this morning." You're the one who has to decide if it's a Bell's palsy or if they're having a stroke, and fast. Some quick clinical pearls. Bell's palsy is often self-limited and recovers in weeks to months. Always assess for stroke signs in anyone with the facial asymmetry. Diabetics are at increased risk for Bell's palsy. If no recovery in 3 months or more, refer to neuro for further workup. Always document an eye exam and management for exposure keratitis. All right, now some practice questions. A 42-year-old man presents with a sudden right facial droop. He cannot raise his eyebrow or close his eye. He denies limb weakness or speech difficulty. What's the most likely diagnosis? Is it A, a stroke, B, myasthenia gravis, C, Bell's palsy, or D, trigeminal neuralgia? I'll give you a few seconds. If you said C, Bell's palsy, you are correct. This is a complete ipsilateral facial paralysis, including the forehead, and this points to a cranial nerve 7 lesion peripherally, like Bell's palsy. All right, question 2. A patient with a new onset left facial droop retains the ability to wrinkle their left forehead but has right-sided weakness. What's the next best step? Do they start prednisone and discharge? B. Prescribe antivirals? C. Order a head CT without contrast? Or D. Refer to ENT? If you said C, order a head CT without contrast, you are correct. Remember, forehead sparing equals potentially a central lesion. We need to suspect a stroke and initiate stroke workup with imaging. So, some final thoughts. Whether you're at the bedside or on a board exam, recognizing the pattern of facial weakness can help you triage quickly. The forehead tells a story. Don't forget to look up. Up next, trigeminal neuralgia, a shocking cause of facial pain you won't forget. If this comparison helped clarify one of neuro's trickier distinctions, leave us a review or share this episode with your classmates. And as always, this is the Pro PA Podcast, where future pros in medicine are made. Catch you in the next one.